Malaysia, Academy of Medicine Malaysia, Asia Eye Genetic Consortium, and Asia Pacific Eye Genetic Society. She is the founding editor for the Malaysian Journal of Ophthalmology and editorial board member of Therapeutic Advances in Ophthalmology and the Open Ophthalmology Journal. With that introduction, Prof. Liza, this is over to you.
Good afternoon to all. So there is another session for ophthalmology in this particular conference. I'll be talking on lessen the pressure to reduce the intraocular pressure. Okay. Right, this is my financial disclosure. Right, I'm sure you have not already heard about glaucoma, but in spite of that, glaucoma is the second leading cause of blindness in the world. Up till now, they estimated 7.7 million are blind because of glaucoma. Most of these glaucoma are asymptomatic, with 50% of the sufferer are not aware about it in developed country, and even in undeveloped country, it's even worse, up to 90%. So because of that, the World Glaucoma Association had come up with this kind of campaign every March, Glaucoma Week. For this year, it starts from 7 to 13 March 2021. Although it's already over, but our campaign will be going on for around with the theme of The World is Bright, Save Your Sight. So what is glaucoma? Glaucoma is basically a progressive optic neuropathy. Okay, and we are talking about optic neuropathy, we are talking about this area. This area is our optic nerve, whereby all the fibers from the retina will go into this optic nerve. So once you have glaucoma, basically, there are going to be a structural changes here in terms of, most importantly, is vertical cup-disc ratio. And this will be manifested as functional changes in terms of visual field. Although most of the time, the previous knowledge that you have, intraocular pressure seems to play a big role, but currently it is just a modifiable risk factors, whereby increased intraocular pressure due to imbalance of production and also drainage of aqueous humor will actually cause a direct mechanical impact to the optic nerve. Okay, there is many types of glaucoma. There's primary glaucoma, of course, secondary glaucoma. Primary is basically whereby there is no ocular or systemic causes that cause glaucoma. And in general, for primary glaucoma and also for secondary glaucoma, it is divided into open angle and angle closure. When we are talking about this angle, we are talking about this angle, which is where your measure is, your iris are, and the ciliary body. Usually the aqueous will be produced here and goes around the pupil, goes into the anterior chamber and drain into the trabecular meshwork. In spite of having the angle is open, something is not right here, so the open angle glaucoma end up with optic neuropathy too, whereby the angle closure is where there is a sort of pushing effect of the iris that was causing a direct blockage of the trabecular meshwork that cause optic neuropathy too. But something peculiar about intraocular pressure, most of us knows that increased intraocular pressure causes glaucoma, but there are cases where the intraocular pressure is normal. I'm talking about normal, which define the normal IOP is between 10 to 15 millimeter mercury. Still, those with normal tension glaucoma develop optic neuropathy. Okay, on the other hand, there is people who have high IOP, meaning like 24 to 32 millimeter mercury, but they do not develop optic neuropathy. That is the complexity of glaucoma. Right. So when I mentioned just now of structural and also functional damage, these are the structural damage that occur over time. That you can see the cup-to-disc ratio over time. Over time is not like 2 days, 3 days, but it's years, okay? And with these structural changes is accompanied by these functional changes. You can see this is our normal visual field in the monocular eye, and slowly it becomes tunnel vision like this. But what more important is, in spite of having this kind of tunnel vision, the central vision, which is usually measured by the visual acuity assessment, is still decimal of 66 or 2020. This is what our patient will experience. Okay, the normal people will see two girls and one boy. Here, the patient slowly, instead of seeing three, they will see one person here. And as the progress, even that one person is just going to be part of the head. Okay? I have patient who complains of that children are feeding them just rice without any dishes, and the children are complaining that their father are not taking any of the fish or chicken. This is because of their constricted visual field. They can just see one part of their own dish for their own lunch. What the most important thing is, another important thing is, all this happen asymptomatically most of the time. Although there are cases whereby it is symptomatic with acute angle closure. So this is what we always call glaucoma as thief of sight. And whatever damage that occurs is reversible, right? But what caused it? Usually when I explain to patient what is glaucoma, I always use this analog of the bulb, the light bulb, and with the wire towards the socket. So the wire is usually composed of many other fibers, which is just like our optical head. And this fiber tends to die off because of many other unknown factors, whereby many have come with the pathogenesis thinking that the direct impact of the intraocular pressure caused this damage. Although there's other issues, there are other studies that sort of like agree with that. So there's other theory was saying that the imbalance of the blood supply to the optic nerve head may cause this. And there are also neurodegenerative, oxidative stress. Everything is always blamed on the oxidative stress. And of course, with the high incidence of risks of developing glaucoma among the family members who have the family history, genetics is also being postulated. Whatever it is, it's just that the nerve fibers tend to accelerate more than the aging process itself. Okay, how do you manage it then? Right. For now, most of the guidelines have this main aim of the management to preserve visual function, because as you know, it is irreversible. So it's very important to preserve visual function at that particular point, to only at that particular point. And at the same time, maintain quality of life so that our patient will be dependent on their family members. How to achieve that is by achieving the target pressure. And whatever the management of achieving target pressure, it has to have a minimal side effect with acceptable cost. Okay, target pressure is always individualized according to the patient, depending on the severity of the disease and also what is the patient needs. Right. Based on many large studies, which is prospective cohort or a randomized controlled trial, still think that whatever levels, whatever type of the glaucoma, at whatever stage of the glaucoma, reduction of intraocular pressure is still the key to the management of the patient. You can see here, this is all the alphabetical soups, VOHTS, MGTs, MTGS. You don't have to remember this. This is just for the ophthalmologist to remember this. Okay, so what are the options for treatment? We have medical treatments. Of course, we have laser treatment. These are all the surgical treatments, okay? But whatever it is, the most common, the first step of the treatment is always a medical treatment. Reason being, it is very popular because it's easy to administer. Just one drops into the eye. There is no intervention, no scalpels, no general anesthesia, right? And at the same time, it's simply effective if the patient is compliant, and it is easy to transport around. You can put in your handbag and there your drugs is. Okay, if you develop any side effect or unwanted effect, it just can easily be discontinued. Okay, right, that was the advantage of medical therapy. So how does this medical therapy works? So far, the mechanism of actions maintained at these three main mechanism of action. Either it's facilitate outflow through the conventional pathway or ureoscleral pathway, or it's reduce the aqueous production. Okay, these are the drugs that have been available, whereby the first invention of the drug for glaucoma begins in 1875, and then it's developed throughout the years. And in spite of this development, we still have only 4 important bullets, which is prostaglandin analog, blockers, carbonic anhydrase inhibitor, and alpha agonist. Of course, the more drugs you have are going to face with a lot of other problems. And the idea of combining drugs begins in 1992. You can see here it's 1992, pilocarpine has already been coupled or combo together with timolol, and later on it comes with dosolomat and timolol, and after the year of 2000, there are many more combination of drugs come into the market. Right. Whatever it is, as to initiate treatment, it's really recommended to start with monotherapy. This monotherapy, you can see all our drugs of choice of that 4 bullets. The reduction of IOP is between 15 to 33%. So of course, if you look at here, prostaglandin analog seems to be a better choice as the first choice of drugs, and we will follow that other drugs. All right. And based on the guidelines, we have our own Malaysian guideline here, and Asia Pacific guideline, European guideline, American guideline. Whatever the guideline is still maintained as to first choice to start with monotherapy. Although there are other drugs, they recommended prostaglandin analog. If it does not achieve the target pressure, then you can either add or switch to another drug and maintain the monotherapy. And it has to be followed up periodically over the years until the patient dies. So it's just like a chronic disease as diabetes mellitus or hypertension. Right? Right. What is the problem with monotherapy? Basically, of our patient cannot maintain on monotherapy for such a long time. Based on a study of ocular hypertension treatment study, after 5 years, 40% of these patients needs more than 1 drug. Whereby in CIGTS, collaborative initial glaucoma treatment study, after 2 years, more than 75% of them need more than 1 drug. Right. So now there is a problems of therapy. One, it is a bit inconvenience. Right. I will explain shortly what is an inconvenience. And of course, when you ask the patient to instill the drugs on their own, they are now become their own doctors. So then come the problem with adherence of the system, which is most important and most crucial part of medical therapy, right? And these drugs, of course, has preservative, because none of these drugs can be maintained a good shelf life without any preservative. And this preservative will cause side effect to the cornea, which is the anterior part of our eye. And of course, there are some side effect and cost to be think about, right? So just imagine that you start your patient on 2 drugs, let's say prostaglandin analog and beta blockers. So beta blockers is twice a day, prostaglandin analog is once a night. So you end up with 3 drops per day, and with 5 minutes, because each drop to have 5 minutes out period. Right, that is 2 drugs. But if let's say these 4 drugs, you have prostaglandin analog, beta blocker, carbonic anhydrase inhibitor, alpha agonist. So you end with 7 drops. With in the morning of 3 drops and at night of 4 drops. You can see the number of each drops will cost at least 1 eye for 4 types of drug at night. One has spent 30 minutes just to drop the eye drop into both eyes. So you think if you get that, then if you do have that, the problem is with adherence. As you know, glaucoma is mainly a disease among the older adults whereby their Alzheimer's come in, their arthritis come in. So there is difficulty to actually drop the eye drops. So you can see here, based on this study, you can see even with one drop, the compliance adherence is less than 50%. What more if it's 2 drops? It's even 32%. So the more complex the regime, the less adherent then our patient will be. Right. So another issue is exposure to preservative. Okay, this is a study by one of my colleagues, whereby she has studied the ocular surface disease among these glaucoma patients, and true enough, all these patients the more the drugs it is, you can see that the more the symptoms of dry eye, and there is also the signs of dry eye. For example, corneal staining, Schimmel's test become abnormal, and TBT. Similarly, that is what she has is primary open-angle glaucoma. Then, as you know, primary angle closure patients tends to have acute attack. When you have acute attack, this will actually compromise a bit on your health of your cornea. So this is another study by me myself, that we can see that those patients who have acute attack and on medication, they have significant sign and symptom of dry eyes. Okay, right. So if you put a lot of medication, the life of the patient will be complicated as this spaghetti junction here. So why not lessen the pressure on our patient and try to reduce this complexity of the disease, and at the same time trying to achieve the target pressure that is so precious to our glaucoma patients. So let's say you have patient on PGNB. Why not we take out the BB and combine it into one drugs? So instead of having to put 3 drops, now you have only 1 drops to put a day, right? How about those with 3 medication? You take out the BB, beta blockers, you combine again, carbonate anhydrase and alpha agonist, we combine it together. So what happened to them now? Instead of 7 drops and have to spend like 30 minutes, now it's only 3 drops a day, right? And maybe 10 minutes at night to complete the dosage, right? So you, based on this, you can see how the life of our glaucoma patients will be much better in terms of their quality of life. But the question is, if you combine together, would it change anything? Would that be compatible to each other? Would the pharmacologically stable? Okay, let's say you have one drug to facilitate outflow and the other one reduce production. That is the question. Okay. Yes, reduce frequency of drugs, no, but is it going to be cheaper? Is it really going to improve the persistent and adherence? Or the side effect will be the same, or the side effect will be less, or the side effect will be more? Okay, so to look into, are they really equal? These are the fixed combination, and on the other side is unfixed combination. This fixed combination and unfixed combination are available in our market today, Right. Let us look into the efficacy first. Okay, look at this. This is a randomized control trial, double-blind study that involved quite a number of patients, of 263 patients, and the observation over 3 months. You can see here, Duotraf is actually a combination of PGA, prostaglandin analog, and beta blockers. This is travoprost and timolol. And this is travoprost alone and timolol alone. You can see that in the week 2, in fact, the reduction are much better, and that continues or sustained over to the month 3, which is 38% reduction altogether. Okay. On the other study, another study on comparative cross-mover mass study of 44 patients. They observed 24 hours intraocular pressure. They compare between 2 fixed combinations. One is latanoprost timolol, the other is travoprost and timolol. That you can see that travoprost seems to have some advantage or much better in terms of IOP reduction compared to latanoprost and timolol. Right? Okay, let us have a look into other studies. FIFERS, for example, compare all these single drugs and also fixed combination drugs with travoprost timolol fixed combination. And you can see in blue here, whereby the intraocular pressure reduced much better than other drugs that are available now. And in general, you can see that all this, there is further reduction compared to the earlier drugs given before. Right. And the same study also look at how the effect on the baseline IOP. And you can see here, whatever the baseline IOP, travoprost antimolol seems to reduce the IOP quite well. Would even better in those with higher IOP, with 30%, those more than 26 millimeter mercury as their baseline before switching in. Right? Right. That is based on single study. This is based on the meta-analysis, whereby this includes 5 studies that come together and see how effective is many of other fixed combination drugs. That you can see here, most of the fixed combination have almost similar or slightly at the edge of better IOP reduction compared to the unfixed combination. But however, this study most of it are over 3 months periods or 4 months, the longest. Okay. All right, and the same study also try to look into the side effect. Yeah, this is the side effect that's been seen with this fixed combination, and it's also compared with the travoprost, whereby the side effect is almost the same. And if you look at here also, it seems that travoprost antimolol have lesser effect as compared to the rest, with the least number of discontinuation of the drugs because of the side effect. Okay, I have this case. This is my patient, an accountant, who was diagnosed with primary open-angle glaucoma for the past 3 years. Both are up to this ratio of 0.8. He was actually started with timolol 6 months, and he failed to achieve target control in spite of him saying that he's really compliant with the drug. We added travatan, then he achieved like the IOP comes down to 40 to 16, although not too bad. Then after that, the IOP medication start to rise up again into 18 to 22 over the period of 6 months. So we have a chat with him. We suggest him either to add on another drugs or change to fixed combination. So he actually opted for fixed combination. This was his baseline. This is the right eye. This is the left eye. So you can see after switching into the fixed combination, the IOP tends to come down and mostly, right? Although the right eye, the left eye has a bit of spike here and the right eye has a spike here, but it's still maintained around 13 to 14 as compared to the earlier of 18 to 22. Okay? Right. The other options that just come into the to our practice recently is a fixed combination with carbonic anhydrase inhibitor and alpha agonist, which is called Liza. This is basically brinzolamide and brimonidine. So these are the studies that have done before. Based on this study, you can see this is the fixed combination and this is the single drugs, for example. You can see that there are slight edge of better IOP reduction over the time periods of 3 and 6 months. Okay? Right. This is my study whereby we have done sort of a prospective cohort study on a patient because these drugs are still not available as drugs in our hospital. So we just offer to the patient who willing to buy on. So I have 8 patients, 13 eyes. These are all patients on 4 medication. Mostly are advanced cases, 5 advanced POA, 1 PACG, and 2 secondary glaucoma. So now their drugs of 4 drugs now become 3. And we still continue follow up. This is our data. What you can see here, initially their main IOP was 23.1 millimeter mercury before we switched to Liza, but continuing PGA and beta blockers. Then at 6 weeks, it becomes mean of 19.1 and it goes a bit up on 20. Do not worry about this because these are all complicated cases. Okay, so but you see that from here it does goes down with Liza. Okay, right. Just now, we switch Liza and continue the other 2 drugs. But what happened those with 3 drugs? Meaning that they have prostaglandin analog, they have carbonate anhydrase and alpha agonist. These are the type of patients that we try to avoid timolol because probably they have some contraindication for timolol, such as those with asthma, respiratory problems, those with heart disease. We do not want them to be on timolol because these timolol are non-selective. We do have selective beta blockers, but it's less effective in terms of intraocular pressure reduction. Okay, so you can see this. This is study in 2019 by Fashner. You can see how these triples, which is triple medication, but it's 2 bottles, that the reduction is much better compared to not on the combination. Right, this is a case, another cases. This Madam RM, who is a retired teacher, she is a known asthmatic, she has a regular, have to pump almost regularly. So at the same time, she was diagnosed with primary open-angle glaucoma, the right eye of 0.9 and the left eye of 0.8, quite an advanced one. So, and she is a bit, afraid of any surgical intervention. So what we did is initially when we started her, initially we started her on PJ, was not controlled. We add on with CAI and also alpha agonist. And her IOP was not so well controlled. You can see here, this on the right eye, it goes on to 23, the left eye is around 16, 17. So we asked her to try if she wants for the fixed combination, and she agreed, and she bought the drugs. And you can see that even the severe eye, how the reduction is and how it is maintained over the periods of 1 year. Okay, that is case 2. Right, that is one issue of the 3 drugs. Now, let's say, how about those who have 4 medication, as I have example before, especially those with advanced cases that we have done our study. And now, with those advanced cases, adherent and persistent is the main issue. And the patients still to be more anxious, more worried because they know that their eyes is at the brink of becoming blind. Or some patients already have one eye blind. Okay, so the adherent and persistent is the main problem. So in this case, if we combine this now, PGA and beta blockers, CAI and alpha agonist, so instead of having four bottles, it becomes 2 bottles. Okay, you can see this is another study that you can see that how the reduction, how remarkable is the reduction of the IOP after these two combination in 2 bottles. And there is also less in terms of audience toxicity. Okay, this is case 3. Another patient of mine, a 69-year-old retiree. He has one eye already blind on the right eye. The other eye, left eye, is 0.8. So he is very worried. Whereby the left eye, we have done surgery, trabecular, failed, and we have started on initially 1 drug, then 2 drugs, and on now he is on 4 drugs. He is not keen anymore for any surgical intervention. But the intraocular pressure is not so well controlled, sometimes 16 to 20. It's not good for one eye patient. This is really a precious eye. And his children agree to actually bought these 2 drugs. And you can see how the intraocular pressure further reduced with a good reduction around 4 months and a bit on 8 months. We're still following him up. We'll see how the intraocular pressure later on after this. Right, what I have shown here now, how we are trying to lessen the pressure to our patient and at the same time achieve the target pressure, which is so precious in those with advanced cases. I would like to repeat this one again. You can see that how the single drugs, the combination drugs make the life much easier to our patients and at the same time, improve their quality of life and reduce the washout effect and make it much better for them. So in conclusion, fixed combination will more convenient, fewer bottles. You can see how 7 drops become 3 drops a day, those with 4 medication. It is as effective as non-fixed, which is very good. And it's a simpler regime, especially those for older patients who have Alzheimer's, who need somebody to remember for them, and perhaps will improve their persistent, less preservative load, less side effect, less severity of ocular side effect. And we can be able to avoid the washout, right? And if you look cost to cost, it will be cheaper than the individual components. Okay, with that, thank you. So always simplify our life, simplify our medication. Life is simple and short to have a complicated medication regime. Thank you.
Cool.
Okay, so that was Professor Liza Sharmini, who gave us an excellent talk on treatment of glaucoma. So we have a few questions already coming in. I will read the first questions now. From Yongshin Yi. Hi doctor, is it possible if a patient who has been treated with anti-glaucoma eye drops for 1 year be diagnosed with not glaucoma and treatment of glaucoma has been stopped after that?
Okay, Assalamualaikum warahmatullahi wabarakatuh and very good afternoon. I was told that around 1,000 plus are still online with us today. Thank you for the question. Thank you, Prof. Samsia. Okay, the question was about diagnosis of glaucoma. As per my presentation just now, you can see that the diagnosis of glaucoma has to be between the structural and also the functional damage. So it's not just the cup to this ratio is the issue, but you also have to have a visual field that sort of correlate with your cup to this ratio. Okay, in general, the cutoff point for the cup to this ratio is around 0.7 and more for you to diagnose glaucoma. At the same time, you need to have your visual field done so that whatever the changes there will be actually correlated with the cup to this ratio. Mind you, some of the optic neuropathy other than glaucoma also may have some kind of increased cup to this ratio. So whatever it is, it has to be correlated between functional and also structural damage. And of course, intraocular pressure is the only modifiable risk factor as for now. So the cutoff point, usually 18 to 20, we are still considering as a normal intraocular pressure. Usually the cutoff point is 21 or 22, above 21 and 22. But mind you, there is also cases whereby we call it a normal tension glaucoma, whereby in spite of having normal intraocular pressure, they can have 12, 13, but there is significant changes structurally and functionally. So this is still called as a glaucoma. It's another type of glaucoma. I hope that's answered the questions.
Okay. We go to the next question from Fatin Shafika. She said, nowadays, so many people doing LASIK surgery. Can LASIK surgery, which causes thinner cornea, cause eye to have high chance of having glaucoma later in life? What do you think, Prof. Liza?
Okay, all right. As you know that the thickness of the central cornea thickness do affect in a way of our accuracy of taking intraocular pressure, especially when you are using tonometer, because this is applanation when you applanate the eye. So you know that the thinner the cornea, the higher the intraocular pressure will be. You are right in terms of that, because when you do LASIK, you have thinner cornea. So most likely you will have sort of higher range of intraocular pressure, but these are not directly translate to the increase of incidence of glaucoma. So far, we have not really seen the significant association between thinner cornea due to LASIK with the incidence of glaucoma just yet. Maybe as more of the LASIK patient age later on, maybe we can have a better knowledge on how this thinner cornea will affect the risk of developing glaucoma in the future.
Okay. So next question is, can empagliflozin and SGL21 cause glaucoma? It's one of the newer diabetic medications.
Yes, it has been recognized that this new medication does affect somehow on the vascular perfusion to the optic nerve head and also to the brain. I was told because it's the same circulation, but so far it is just based on one or two of the case report, but there are not a significant number or a very strong evidence to say these drugs will actually cause increased risk of glaucoma as for now. So there are also other drugs other than this drug, even we would say hypertensive drugs that does affect the perfusion to the optic nerve head. As you know, when the perfusion is imbalanced, you may have some damage to the optic nerve head that will cause some kind of functional damage and structural damage that is actually part of the diagnosis of glaucoma. So we just have to wait and see as the drugs goes. I mean, more people are using it, then maybe we can have more conclusive evidence to see how does this affect risk of glaucoma in the future.
Okay, I think the next two questions has been partly addressed by Prof. Liza just now from Gayatri and Shantini. Both of them ask at what point is treatment initiated, what is the cup to this ratio, and what is the IOP. I think Prof. Liza just now mentioned it was 0.7 and above and more than 21 or 22. And Shantini asked, a person with normal tensive glaucoma with pressure around 10 to 12 for 2 years, the patient has to continue with the taflutan eye drops.
Oh, of course. This is not, as I mentioned just now, a normal tension glaucoma can have a normal range of IOP, but still the damage is there. So since you already diagnosed with normal tension glaucoma, they have to continue with the medication throughout their lifetime. And we have seen those who have even reached a target pressure, which is, let's say, the target pressure is very individualized as per my talk just now. So even they achieve target pressure, they still can develop functional damage later on in life. So they have to still continue with the treatment and follow up accordingly.
Okay. Next question is from Ang Kiam Huat. Can blue light from handphone cause increase the risk of glaucoma and sudden blindness? What eye drops is effective to protect the eyes from blue light? Okay.
This blue light issue has been, I would say, a very controversial issue, and a lot of opinion from the optometrists, from us ophthalmologists, from the GP. It's really non-conclusive, even if what they have been advocating is basically reduce the screen time, make sure your eye relax, because there is also evidence to say there is no direct effect of this blue light to the eye. Even so, on glaucoma is even so less effect as compared to the rest. So there is no magic medication so far to reduce the effect of this blue light. So far, they just advocate lesser the screen time, rest your eye. Resting your eye is including that you have to look far or look at the green for 10 minutes before you continue with whatever you are doing, so that your muscles of the eye, your lens and everything will relax. And then, of course, the more time you spend on screen, sometimes you can develop dry eyes because of the light that emitting from the thing. So the other thing is just to put artificial tears. But so far, there is no specific medication to avoid this blue light. And even this blue light are not really conclusive enough to cause, detrimental effect to the eye.
Okay. Right. The next question would be, what's the difference between acute and chronic glaucoma? When do we say acute and when do we say chronic?
Okay, the acute glaucoma, this is usually when we're talking about acute, usually we refer to acute angle closure or any situation whereby the pressure suddenly goes up. And this one we are saying going up is not like 24. We are talking about 40, 50, 60, or even 70 or 80. When this one is so high, you will have symptoms, which include sudden reduced vision, painful red eye, halos around the light, headache, nausea, vomiting. These are the acute symptom. The chronic symptom is usually there is not much symptom. You don't feel it. Okay, so far even in acute angle closure, you can have acute on chronic, meaning that they are ongoing chronic glaucoma already. Intermittently, they have this kind of acute attack. But the acute attack or even the IOP is actually depending on how the endurance of the eye or endurance of the patient, because some patients, they are so used to high IOP, even 30 was like nothing to them.
Yeah.
For some patients, 30 is so they can get a lot of symptoms, but many of ours, Asian especially, the older one, 30 is like nothing to them. 50 will be that, you know, when we hear 50 was so high, but 50 are more, they consider it as acute, 30 as just nothing, is just a chronic type. So most of our glaucoma are chronic, but they are acute type. So acute type can occur at any time, even during the chronicity of the disease.
Yeah.
Okay.
That's very true. Okay, we go on to the next question. Must Zalatan Zalatan be taken at night? Could it be in the morning?
Oh, okay. I think study have been done because Zalatan alone is best to use at night because it's been proven any PG analog, the reduction are more drastic at night compared in the morning. They have done study to do in the morning or at night. But if it's combined to timolol, there is some controversial. Some say can still give at night, but there are finding to say that in the morning will be much better because timolol works well in the morning. So in that, I still prescribe my patient on morning if they are on combi, but some still prescribe at night because I found my patient sort of respond well if it's on morning compared to at night.
Okay. Is it safe for pregnant lady to use tropicamide eye drops for eye examination?
So far, I think I don't have any, I mean, we haven't have any problem of using tropicamide on pregnant ladies so far. And it's just examination. It's not on chronic usage. So less likelihood of tetralogical effect to the baby, to the fetus at whatever trimester so far. That is what I haven't have any experience. Do you have any experience for Sham?
No.
I don't think so.
Normally it's just one drop, and if you were worried about teratogenic effect, then you could just occlude the punctum. That should be okay.
Yes. Okay.
Next question is it safe? Sorry, no. Can doctor comment on steroid-induced glaucoma? From Jennifer Audrey.
Okay, this is another good issue, a controversial issue too. Okay, steroid. Sometimes one issue is when complementary medicine that we do not know of that actually put steroid inside, either orally, nasally, or even topical, meaning a cream like, or even so the eye drops. That is one issue. The other issue is sometimes a general practitioner or even ophthalmologists do prescribe steroid, topical gut steroid for those who have, you know, allergic reaction or those kind of thing. It's meant to be used for a short term, but you know, some of our patients are very good. They go and buy on its own or buy over the counter. So all these two steroid dosage from either is a complementary or either was abused by the patient can actually cause steroid-induced glaucoma. Basically, it seems that this will play around with the GAG, glycoaminoglycan, that will actually clog the angle and clogging of the angle, but the angle is still open. It's just clogged the angle so that the aqueous cannot actually pass through it. Then it will cause increased intraocular pressure. Again, it is a chronic kind of thing. And slowly it was reduced. They will cause reduction of your visual field. Sometimes most of the patient, those especially who have allergic conjunctivitis, I'm sure you have listened to Dr. Fazilawati just now of allergic conjunctivitis, they were happy with the steroid drops because the eye redness all go off. but they did not know at the same time they are inducing another disease that will actually cause visual impairment, even blindness. We have seen a lot of cases like this. And on top of that, there are a lot of other complementary medicine, you know, like in among the Malay will be majo, and some even coffee 3-in-1, 5-in-1 have steroid inside that. So some of the patient, especially the older adults, the elderly one, they are so used with this because once they drink this coffee, they are more energetic without knowing it is steroid inside that. That is what we are worried about. That is what our association were trying to combat, this kind of unregulated selling of illegal steroid in supplementary kind of medicine. I hope that answered the questions.
Yeah, that's quite clear. Next question is, can patient be allowed to go on drug holiday after having attained normal IOP?
Definitely not.
No.
No. That is a bit no.
No.
Because most of the time patient, once they say they don't have symptoms or they feel they are better, they thought they are cured. But glaucoma is never cured. It's irreversible. The only thing that we are putting medication, we do surgery, we do laser, is just to retard whatever the future destruction. Whatever happened before is irreversible. So there is no drugs holiday.
It's like you have hypertension, high blood
Yes.
pressure, and you can't go on holiday if you have high
Yeah.
blood pressure. Okay. From Tang Zi Wen, can lutein, zeaxanthin, and astaxanthin combine with the ocular medication to prevent the worsening of glaucoma?
Wow. Okay. There have been a lot of study on this, I guess, but non-conclusive outcomes so far. They are talking about this could be some kind of neuroprotection, but it does not really work very well. As supplementary, I would say yes, but meaning that they can take this as supplementary. I know a lot of supplementary medication that been sold. They say they have lutein, xanthin, and everything, but to actually reverse or take off the what medication we are being given, it does not really works. You can just take it for as supplement, but not as a main treatment. Yeah.
Because I know some studies show color, if there are changes, that the changes is not enough to prevent from worsening of glaucoma.
Yes.
All right. So from Lim Pei Zen, what is the prevalence of glaucoma in Malaysia?
Oh, that is actually, we'll call that a soalan cepu emas. Because we haven't done any epidemiology study in Malaysia. You know, epidemiology study is quite expensive. So we do not have a direct incidence of prevalence just yet. What we have so far based on National Eye Survey 2, whereby it's more towards the prevalence of visual impairment due to glaucoma or blindness due to the glaucoma. Even that in this study, it is not so accurate because the diagnosis of glaucoma is just based on fundoscopy, further IOP was not really taken, visual field was not really done. But that is the best that we have so far. I think glaucoma is the third out of the rest of cataract and refractive error. So we are the third. In certain state, I think could be second or even first in certain states. But so far we are trying to get it through a secondary data whereby we are trying to postulate from other data from Singapore Malay Eye Study and a few study from China and India to postulate what are the prevalence of glaucoma in Malaysia. But I think that is still in the pipeline. We are still writing on that. We're going to be submitted soon. So maybe that is the only good thing that we can have right now. And I know many concern because there's a increase of a lifespan of Malaysian, or automatically this age-related disease, including glaucoma, will be increasing soon lah.
Yeah, although it's the third, but it's the first in irreversible blindness, right? So you can reverse the other two, but you can't reverse glaucoma.
True.
Okay. Can chronic constipation worsen prognosis of glaucoma?
Not
Better get
directly,
that
I
fixed.
guess. No, I think they were talking about Wasava
Wasava.
maneuver but Wasava maneuver in chronic constipation, usually they cause retinal hemorrhage, subretinal hemorrhage rather than glaucoma itself. Of course, there will be sort of like you were holding your breath for a while. You were thinking that this holding of Wasava maneuver may actually affect the blood circulation to the brain, and of course to the optic nerve head, but there was not a clear link to it. But subretinal hemorrhage, yes, because of the increased pressure in thoracic pressure and everything, you do get subretinal hemorrhage.
Okay.
Yeah.
Next question from Sarisa. Is it possible to reduce risk of glaucoma or cataract in a patient with high myopia?
Okay, all right. Cataract, I think in high myopia is a known facts. Usually you get early cataract, either you get polar or PSCC, or even usually you know that nuclear sclerosis are more age related, but this one, if you get polar or posterior subcapsular, is more of like related to refractive error things or other causes. But in terms of glaucoma, diagnosing glaucoma in myopia is a challenge, I would say, because your disc sometimes will be sort of not centered. So your disc will be tilted, and this tilting of the disc, and also at the same time there were retinal changes, actually can mimic glaucoma. That is one thing in terms of structural and functional damage. Even you can see structurally and functionally, sometimes it can mimic glaucoma. And of course, you know that these the high myope usually have thin cornea. So again, the IOP will be high. So we have to really think twice or thrice before to make a diagnosis of glaucoma in myopia.
Okay, Ahmad Lazwardi Jahidin has got two questions in a row. What type of exercise can cause glaucoma, or that might cause glaucoma, and what's the difference between open and closed angle glaucoma?
Okay, I answer the first one first, the second one first, because it's easier. Okay, the open angle glaucoma, again, we go back to structure of the eye. Between the cornea and the iris, there is actually what the structure that we call an angle. There is where your trabecular meshwork will be there. So there is where your aqueous, which is produced from the ciliary body behind the iris there, near to the lens there, that will actually go through the pupil and drain into this angle. So open angle meaning there is nothing wrong with the drainage system, but somehow the aqueous does not go into the drainage system. The closed angle is meaning that the drainage system is clogged, either due to the iris itself that pushing, or there is a posterior anterior syndicate that sort of limit the flow of the aqueous into that. That is the difference between open angle and closed angle. So again, this open angle and closed angle can be primary or can be secondary. Primary meaning that there is no causes, no ocular, no systemic. It just occurred that way. Secondary can be systemic, can be ocular, can be anything that causes it. Okay, about the second question was on what is it?
Exercise. What
exercise.
Type of exercise
Okay,
that might cause glaucoma?
Okay, exercise is been known that certain form of exercise can induce increase of intraocular pressure. Like for example, if you are into yoga and you put your head down, for example, that can increase the intraocular pressure. And certain exercise, particularly I would say isotonic exercise, aerobic exercise that is just a short period of time will not cause increased intraocular pressure. But those who like weightlifting, for example, that will cause intraocular pressure. But whatever it is, even if it cause intraocular pressure, it is on the short period of time. Directly causing glaucoma was not really certain, but it does cause increased intraocular pressure. Maybe it's not suitable for those already having glaucoma or at risk to get glaucoma.
Okay. Jennifer already have another question. If asthmatic patient need to have maintenance inhale corticosteroid daily, how can doctor advise to prevent glaucoma?
Oh, okay. This one is one of the thing is the inhaler. Yes, we have cases that reported that steroid inhaler does cause secondary glaucoma. One important thing is to refer to us. Let's say really need frequent one, not well controlled. Either you have to refer to the respiratory so that they can give a better management on that, and to us also, so that we know if we detected the IOP is increased and there is structure, we can treat early. One thing about glaucoma, if you treat early, you may actually save vision. Occur or not to occur on a long-term steroid is a different issue.
Okay. There are a few questions on drugs now. The first one is, can you take Q10 for cataract or glaucoma prevention to reduce oxidative stress? And then another question on, does oral pseudoephedrine worsen glaucoma?
Okay. Q10 is a complementary, I guess,
Yeah,
right?
it's a yeah.
Xanthine kind of, lutein and xanthine kind of, I think that I have answered the question just now about the lutein and xanthine. The other
I
of
think it's a antioxidant or something.
antioxidant, okay.
Yeah.
All right. Antioxidant does help actually in terms of reducing progression. We do not know either it can prevent glaucoma per se, or not so sure, but in terms of reducing progression, it does help because it's oxidative stress, because some of the theory of how this pathogenesis of glaucoma occur is due to oxidative stress. But again, this could be a supplementary. If you have glaucoma, you can use it as a supplementary, but not as the main medication. Okay, the other one,
Oral pseudoephedrine. Pseudoephedrine, I think,
okay.
is
Yeah, the
runny
steroid,
nose,
runny nose. Pseudoephedrine is actually combi, right? The steroid plus the, I can't remember, was it?
It's what do you call that? It's something starts with A. No, it's not Ativan. Is it Ativan? But it's a combination of epinephrine plus something else.
Yeah. I think so far there is no reported cases just yet. But whatever it is, if you have to use it for a long term and you are worried, you can just refer to the ophthalmologist to have a look.
Okay. All right. Because of the shortage of time, I think we have to conclude our Q&A session now. For those who still have questions, maybe can contact the secretariat so that we can answer them. I would like now to thank Professor Dr. Liza Sharmini for giving the wonderful talk as well as answering all the questions perfectly.
Okay.
We do hope that you have gained a lot of insight with this session, and we would like to thank all the audience for being with us today. The next section will be Let's Talk with the Expert, Get Your Question Answered on Oral Contraceptives, which will start at 3:10. Do stay tuned if you're interested. With that, I would like to conclude the session. And Prof. Liza, do you have any last messages to tell our audience?
Okay, thank you for being here today. I hope that with my talk today, you will able to understand glaucoma and able to understand the complexity of glaucoma and better manage your patient later on. Okay. Thank you so much for the opportunity. Have a nice day.
Yeah, have a great day and goodbye.
Yeah, bye.
Assalamualaikum.